Uh,
He was a great intern.
wow, that sound. All right. Hey, everybody. I'm Mohammed. I'm a recent graduate, I guess, from your program. For those who don't know me, currently doing my GI fellowship at SUNY Downstate in Brooklyn. So the topic, I chose this topic today because it's something that we never get exposed to, in residency, and typically don't get a lot of exposure to liver stuff. So I think it's very important for you guys and for all of us, like, to know how to deal with these acute liver injuries. It's a very broad topic, but I'm gonna just touch on the basic principles of how to deal with these abnormal liver enzymes and what to do with them and all that. Okay. So I'm gonna start with a case. It's more of a complicated case, but we can go over it. So patient is a 50-year-old guy. He presents to the hospital with 6 days of fatigue, malaise, and multiple episodes of non-bloody, non-bilious vomiting, and abdominal distension with diffuse abdominal pain. And 3 days prior to his presentation, he was noted to be jaundiced, and so was brought into the hospital by his family members. He had hyperlipidemia, and 7 months prior to that admission, he had taken an unknown cholesterol-lowering medication for a period of 2 months. And he currently takes no other medications, no herbal supplements, no over-the-counter alternative medicine stuff. What else do you want to ask about his history? Somebody presenting with jaundice, abdominal distension, confusion, malaise. What is something pretty important to ask?
When did it start?
Okay.
Alcohol.
Apart in terms of his past history and social history and stuff.
Alcohol.
Alcohol, right. So he says he last drank alcohol 6 months before the admission, and he previously drank in a binge pattern, 8 to 10 alcoholic drinks at a time, and several days per month. He also resided in rural community in northern India and worked as an horticulturalist and had cattle on his property. And his father had reportedly died of an unspecified form of liver disease in his 6th decade of life. There's a lot of, so it's just giving you a lot of differentials, okay? So this is his physical exam. So his temperature is fine, his blood pressure is 138/82, and his heart rate is 90. He's breathing at 14 breaths a minute, but he's setting 94% on 4 liters. He was alert and oriented without hysterexis, and his skin was jaundiced, clear or icteric, and there was no spider angiomas or pulmonary erythema, which means there's no like signs of liver disease, of chronic liver disease at least. And the rest of the exam is pretty normal, apart from the mild distension of the abdomen, essentially, with minimum diffuse tenderness to palpation. So these are some of the labs that, there's a lot of labs here, but essentially it's just a trend of labs, okay? So I don't want you to look at everything. I really want to highlight a few of them, okay? One of them is the hemoglobin. So the guy, when he showed up, is 11.8, but then as it progresses, you can see his hemoglobin went down to 5.9, and then he probably received some blood and was 7.3. And he definitely had a white count up to, I don't know if you guys can see it, but it's up to, 15, goes up to 30. And then his platelets, I highlighted this, pretty important. So his platelets are always like elevated, the 200s. Does this exclude something in terms of liver problems for you guys? Anybody, when you see low platelets, what do you think? What's that?
Cirrhosis.
Cirrhosis, why?
Because you have myelosuppression, potentially.
So, right, exactly. So you get some sort of myelosuppression with cirrhosis, but more importantly, you get portal hypertension and splenomegaly, which sequesters all the platelets. So people with low platelets, less than 150,000, you think of portal hypertension. This is a very important kind of point. And then they mention his INR is 1.9, pretty stable. He has a low haptoglobin. Does that give you something? Is that like give you an indication what's going on?
Hemolysis?
Hemolysis, right. So the guy is hemolyzing. That's the hemoglobin is 5, the haptoglobin is low, hemolyzing. But more importantly, let's look at his LFTs, or the LFTs, the liver enzymes. So he has an ALK phos of 194 and a T-bili of like 27, ALT 4,000, and AST of more than 3,800. At this point, what would be your differential for this guy coming in with these high numbers of liver enzymes?
Viral hepatitis.
Viral hepatitis. Okay, so viral hepatitis. Um, I'll give you a bunch of others. Ischemic hepatitis, drug-induced liver injury. All these are, especially acetaminophen. All these can be a cause. So essentially, it's acute liver injury, secondary to something. And I always say, really insert all causes of hepatotoxicity here, like anything. It can be secondary to anything, but hopefully during this lecture, I'll get you guys to know what's, how to differentiate, how to put them in buckets. Okay, so this is really the differential diagnosis of acute liver injury in general. You have either viral infections, you've got the drugs and toxins, acetaminophen being the big one, mushroom poisoning, metabolic and genetic disorders such as Wilson's, infiltrative disorders, cancers, pregnancy related, such as HELP, fatty liver disease of pregnancy, and some other ones like, Rey syndrome. You'll never see, this is in kids, and other things. Ischemic hepatitis is a big one, and Budd-Chiari, okay? So this is generally like the acute liver injury that you see, generally secondary to one of these, okay? So, the liver is a highly vascular organ, right? This is the histology of the liver. You've got the portal triads, right? You've got a portal vein and you've got the hepatic artery branch. They go into the liver, and then you've got a biliary duct or a ductule, and they all go into the sinusoids, and then they end up in a central vein. And the sinusoids are lined by the hepatocytes. So the hepatocytes make cords of cells. In between them, there's blood, and the other side, there's bile. And if you look at the liver as a structure, there's three structures going inside the liver, right? There's a portal vein, there's the hepatic artery, and then there is the bile, the bile duct or the common hepatic duct coming out. So the flow is this way, right? The blood flows this way and the bile flows the other way. And then, the blood will end up in the hepatic vein, which is, the hepatic vein is such a small vein. It connects right into the IVC and right into the right atrium. So there's a really strong relationship between the right atrium, the right side of the heart, and the liver. The hepatic vein is merely non-existent. It's such a small vein that it's really the IVC. So when we say IVC, hepatic vein thrombus, it's almost like saying an IVC thrombus. It's a big thrombus, okay? So transaminitis, right? What does it mean? So this is the word that we all use, and a lot of people don't want you to use it because it just means inflammation of a transaminase, and that doesn't make any sense, right? It's like saying creatininitis or tropininitis. So instead, we want you to use elevation of liver enzyme or liver enzyme elevation, right? Or liver chemistries. The other thing is LFTs. We always say LFTs referring to the ALT, AST, alk-phos, versus the really true LFTs, right? So what's the difference, right? You have the LFTs, the ones that we commonly say LFTs. These are the liver enzymes or liver chemistries. These are the tests that reflect the integrity of the hepatobiliary system. So the cells themselves, they contain these enzymes, and when they break apart, when they die, these enzymes will be in elevation in the blood. And these are the ALT, AST, GGT, T-bili, all these things. T-bili is kind of considered both. And then there's the liver synthetic function and other functions. These are they reflect the physiologic hepatocyte function, right? So what are these? What are the liver synthetic, the true function tests?
Albumin.
Albumin.
Okay, what else?
INR.
Clotting factors.
Okay, cool. So albumin, prothrombin time, and bilirubin also, okay? So the hepatocyte, you guys remember this? This we were lied to. This only happens in the hepatocyte, not everywhere in your body, okay? Because the hepatocyte contains all these enzymes. So really the metabolism of hepatocyte is such a complex thing that happens, and any problem in any part of the way, any enzyme that is inhibited in any part of the way will cause liver injury. So it's a really complex, cell, the hepatocyte that governs the metabolism of all your body. And that's why you can't live without a liver. It really does all the metabolism of your body. And the liver enzymes, they're distributed within the hepatocyte. So if you look at a hepatocyte, it has a basolateral membrane that has blood on this side, and it has a canalicular membrane that has bile on this side, all right? And then it connects into the bile ductules, the cholangiocytes. So inside the hepatocytes, you have the AST and ALT, right? Swimming right here. But also you have AST in the mitochondria. It's very important. So there's two types of AST. There's a cytosolic AST and a mitochondrial AST. And then you've got, the ALK phos and GGT, they're kind of on the canalicular side. And that's why when you have hepatocyte injury or canalicular injury, then the ALK phos and GGT will be elevated rather than AST and ALT. Okay. So are all these enzymes specific to the liver? And obviously the answer is no, right? If you start with AST and ALT, if you look at AST, is really not that specific to the liver. AST goes in a gradual concentration, lower concentration as you go down this ladder. From the liver, goes down to cardiac muscles, skeletal muscles, kidney, brain, even in erythrocytes. Somebody with hemolysis might have elevated AST. However, we always say the ALT is more specific to the liver. It's more found in the liver, not found in anywhere else. So when you have ALT elevation, think of liver diseases. When you have AST elevation, it could be anything, including liver diseases. I mean, it's still in high concentration in the hepatobiliary system. And so this ALT, AST, they have certain functions in hepatocytes. What do they do in hepatocytes? So, as the name implies, they're transaminase, right? They translocate an amino group. They essentially turn an amino acid into a keto acid and the other way around. Okay, and they go both ways. So, you have the ALT, which produces pyruvate and glutamate. And that's why they call it, the glutamate pyruvate transaminase, GPT. That's the other name for it. You might go to some EMRs that use SGPT and SGOT. So you should really know these as well because they get confusing. But this is why they call it GPT and GOT, because one is oxaloacetate glutamate and one is pyruvate glutamate. Meanwhile, ALT refers to the alanine and AST refers to aspartate. How about ALK phos? So ALK phos is, it's a group of enzymes. It's not one enzyme. It's a group of isoenzymes. They're really found mainly in the liver and biliary tree, but there's other places where this is found. And these 5 places or 6 places you should really know. So it's in the liver, biliary tree, but it's also in the intestinal epithelium. So if you have intestinal epithelial damage, you'll have ALK phos elevation. In the kidneys, people with chronic kidney disease, they will have ALK phos elevation. In the bones, and specifically in the osteoblasts, not in the osteoclasts. So if you have bone lytic lesions, ALK phos will be normal. If you have bone blastic lesions, then the ALK phos will be high, or like Paget's disease or something. And then finally, in the placenta. So pregnant ladies will have high ALK phos, and that's not a sign of liver disease. And so if you have an ALK phos elevation, if you see a patient and you see, the ALK phos is elevated and it's just isolated, they only have ALK phos, what would be your next step?
GGT.
GGT, right? So you want to differentiate where this ALK phos is coming from because it comes from so many different places and GGT is more specific to the liver. So you either do a GGT or you can fractionate the ALK phos. You can do a fractionation and then it tells you, oh, the ALK phos is coming this much from bone, this much from liver, this much from intestine, whatever. So if it's a bone origin, then you look at bone evaluation. Now, if it's a liver origin, the first thing you want to do is review the medication because a lot of medication are what we call cholestatic medications and they cause a elevation in ALK phos. But also you want to send an AMA level. Why AMA?
Primary biliary cirrhosis.
Yep, primary biliary used to be called cirrhosis, now called cholangitis. So primary biliary cholangitis, and then ACE levels because of sarcoid can present in a cholestatic pattern, and then right upper quadrant sonos because you can have a extrabiliary ductal dilatation and blockage. So, if you see the bile ducts are dilated, then you go to ERCP or MRCP, whatever they want to do. If the AMA, ACE levels, one of them is elevated, you're suspecting some sort of intrahepatic pathology, you might end up in a liver biopsy. And then finally, everything is negative, then you do an MRCP. The reason is because sometimes you can have primary sclerosing cholangitis that can be intrahepatic, that is inside the liver. It's not visible on the ultrasound. And then you want to look for that, okay? Just a few words about GGT. We just mentioned that it's more specific to the liver. So it's predominantly in hepatobiliary disease. It's not found in the bones. And so it confers to a liver origin when GGT is elevated. However, you should always remember that GGT is an inducible protein. What does that mean? The levels of GGT can increase by alcohol drinking, by barbiturate intake and phenytoin uptake. So you can drink alcohol and GGT will be elevated and without any apparent liver injury. So not necessarily you will have any liver injury. It's just because the enzyme itself, it's inducible by alcohol. And that's why we actually use it in alcoholics and people who come in with like alcoholic hepatitis or whatever, and then we follow them in clinic, we send the GGT always. And if the GGT is high, we suspect these people are non-compliant. They've been drinking, okay? And then you can see the percent of drinking days, the more you drink, the higher your GGT levels go up. And this was a study looking at comparing African-American versus non-African-American males and females, but still it's high in everybody essentially. There's other biomarkers that we look for, like the MCV will be high, people who drink, but the GGT, just know that if you have GGT elevation without alk phos elevation, so that's why you need to send both. You can't just send GGT and say there is liver disease, because it's an inducible protein. Okay, now the other synthetic, functions, the other synthetic tests that we do, we said albumin and prothrombin time, right? Albumin, so it is the most important plasma protein. Think of albumin as like the garbage disposal system of your body. It binds everything. It binds drugs, it binds, metabolites, it binds everything in the body. It binds even normal stuff that, shouldn't bind sometimes. It is exclusively produced by hepatocytes. So nothing else in your body can produce albumin. If your liver goes, you have no albumin, you die. And the total body albumin is 300 to 500 grams, and its half-life is about 20 to 21 days. So I mentioned this because a lot of the times you will get into situations where, your liver fellow, GI fellow will ask you to give albumin for people with suspected hepatorenal syndrome, or give albumin with somebody with SBP. And, we always say, give, 1 gram per kilogram of albumin. And, pharmacy freaks out. And they're like, this is so much albumin, it's just so much. You're giving like 20 bottles of albumin for one person. And it is reality, because in these situations, we are worried that the liver stopped producing albumin. And we worry about that. You really want to replete the albumin, in the body. And if the body contains 300 to 500 grams, if you give for an 80 kilogram guy, you give 80 grams of albumin, that's nothing, right? But it's still a substantial amount when we think. So always have it in the back of your mind. When you give that much albumin, don't be afraid. It's fine. We have so much albumin in our body. So if albumin is so important for liver disease, can you measure albumin to screen for liver disease? Let's say if I have low albumin, does that mean I have liver disease?
Not always. It can decrease with other stuff.
Yep. Exactly. So you can't really use it as a screening tool. Okay. However, you can use it as a predictor of survival and mortality in patients with chronic liver disease and cirrhosis. Think of all the Child-Pugh scoring, as other scoring systems, they all use albumin as part of their criteria in predicting mortality. So always, in chronic liver disease, you can use it. You look at the albumin for somebody who's an outpatient, the albumin is like 2. That's a bad prognostic sign. Okay. The other thing is prothrombin time, right? Prothrombin time is this part right here, the extrinsic pathway. It has nothing to do with the intrinsic pathway. And this measures primarily the vitamin K dependent factors, which are 2, 9, 10, and 7, right? And these are the procoagulation factors. And vitamin K, they're dependent on vitamin K, and if you inhibit them or you stop producing them by the liver, the PT will go up and the INR will go up, right? So all of these factors are really produced by the liver, except, anybody shout an answer?
Factor 8.
8.
Yes. Where is it produced?
Vascular endothelium.
Yep. So this factor 8 is produced in the endothelium and stored in the endothelium, while the rest, everything else is in the liver, okay? So if you have liver disease, you'll have high prothrombin time, you'll have high INR, okay? And if you have high INR, our general conception of what an INR is, it's almost like bleeding time. How much can you coagulate your blood? So if somebody has a high INR in the setting of liver disease, are these people more prone to bleeding or not? So if I have somebody with cirrhosis with an INR of 2.5, and they have a mitral valve, do you need to anticoagulate this person?
Yes.
Yes. Why? Why is the INR not reliable in this setting? So the answer is, we talked about all the vitamin K dependent factors they produce. We said all these factors are produced by the liver, but what we always forget is that not only procoagulant factors are produced by the liver, but anticoagulant factors are produced by the liver, especially protein C, protein S, antithrombin, right? So these things are also decreased, and we have no way of measuring them. We only measure the PT and INR, and this will take into consideration the procoagulant factors, but that will not measure the anticoagulant factors. So in fact, people with liver disease are actually highly prone to coagulation, and they will coagulate, they will form thrombi all over. And this is a good one to know. About 20 to 25% of people with cirrhosis will have portal vein thrombus. So it's a high percentage. These people are, even though their INR will be like 2, and you'll still need to anticoagulate them with something else, like a heparin, Lovenox, or like a DOAC, okay? And then, a little bit about bilirubin. We always think of bilirubin as like this structural, there's the bilirubin cycle where it goes from the liver, goes to the intestine, to the kidneys and all that. That's pretty important, right? But what I want to focus on is bilirubin as a functional liver test. And the way you want to think about it is because, you destroy your RBC, you destroy your hemoglobin, the heme, then you get biliverdin, you get bilirubin, then it goes into the liver, it gets conjugated. So there's the act of conjugation, that's part of the liver function. And then there's the act of transport. So remember, there's the sinusoidal side and there's the canalicular side, and the hepatocyte is going to transport bilirubin from this side to the other. And this act of transport is an active function of the hepatocyte, and any damage to the liver will cause this function to be disturbed. In fact, if you have problem with transporting bilirubin in somebody with hepatocellular injury, that's a really bad prognostic sign. That's very bad. So always look at T-bili, and don't look at it as just an obstruction like a cholestatic part. It's also asymptomatic. It's a functional part of the liver, okay? Here's another quick question. So which of the following decreases in acute phase? And
Albumin.
There's two answers here. Albumin. Anything else?
C3.
The complement.
It's kind of weird. We never heard of it. So alpha fetoprotein decreases. And the reason I mentioned this is a lot of times you see it normal. If you send it in somebody who has like chronic inflammation, whatever, that doesn't really exclude hepatocellular carcinoma. So alpha fetoprotein, we see it in HCC as a screening tool, but in the setting of acute stress, you don't use it. And then albumin, it's pretty obvious. You got the albumin just, disposing with all these acute phase reactants, and it's just binding everything. So the levels go down, okay? So, which comes to the important, now that you know all of these liver tests and different liver tests, now there's two types, or there's like multiple types of abnormal liver tests. There are really not just two types, multiple, but mainly two. And in order to understand them, again, we need to look at the hepatocyte again. Look at it and see, like, you've got the ALT, AST swimming inside the hepatocyte itself, and the AST in the mitochondria. You've got the ALK-Phos GGT swimming in the canalicular side and in the cholangiothelium. And based on that, you can classify, right? There is a hepatocellular pattern and there's a cholestatic pattern, right? If you have a hepatocellular pattern, it means the hepatocyte itself is injured. And what leaks out is usually AST and ALT. These people do not typically have jaundice, but if they do have jaundice, then it is a bad prognostic sign. They won't have pruritus because they don't have conjugated bilirubin hanging out in their body, and they technically can go into acute liver failure because the hepatocyte itself is being destroyed. While a cholestatic pattern just means that there is a slowing down in kind of the transport of the bilirubin and the bile through the ductules, and that will back up into the liver and damage the hepatocytes. And that will include, high ALK-Phos, high GGT, high T-bili. And, in general, when you look at these two, which one would you rather have? I mean, you'd rather have neither, but cholestatic pattern is more benign in a sense than hepatocellular pattern. This one, the mortality can go up to 10%. And then you have a mixed pattern. It can start this way and become the other, or can be hepatocellular and cause jaundice. Then it becomes, then it becomes confusing. So if it's confusing, if you see somebody and you're like, I don't know, this looks like, the ALT, AST are elevated, but also the ALK phos and TBL are elevated. I don't know if this is mixed. I don't know what this is, right? Is there like a score? Is there a thing that can guide you?
R
R
ratio.
factor.
R
R
factor,
ratio.
right? R factor. Yeah, that's a good one. So the R factor looks at the ALT and the ALK phos ratios. So you go to the ALT divided by the upper limit of ALT, which is typically 40, divided by ALK phos over the upper limit of ALK phos, 120. And this can give you an idea whether it's hepatocellular. It's not always perfect because some people can present with a mixed picture, but also can have like other reasons for ALK phos elevation, and then it becomes confusing. But for a typical liver injury, this is a good test to always put in your notes, or like just review it, just see what's going on, and then it will kind of narrow your diagnosis. Okay, so if somebody does have a cholestatic liver injury, then what do you do? This is what you do. First thing is you review your drug list. Okay, you look at the drug list, because again, we said some drugs are cholestatic by nature, and then you do a right upper quadrant sauna. If you have duct dilation, then you got the diagnosis, right? And you have some sort of compression. You want to do an MRCP, ERCP. You want to see what's going on. There's a tumor, there's a stone, there's something. If the ducts are not dilated, then you end up with this dilemma of like something else is causing the cholestasis. It's what we call intrahepatic cholestasis. So it's within the hepatocytes, the biliary ductules. Then you send the tests we mentioned earlier. You send AMA, ACE levels, but you also want to send some of the viral serologies, because again, sometimes hepatocellular injury can be so severe that the ALT and AST start going down because there's no more of them. You damage so much of your hepatocytes that they're not leaking anymore, and you still have ALK phos and TBL elevation. So you still want to at least rule out viral etiologies of liver injury. And if the AMA ACE level is positive, something's going on, then you do a liver biopsy to confirm. Sometimes you don't need to, but a lot of the times you just want to confirm. If the evaluation is negative, then as I said earlier, you do an MRCP, because you want to look at small duct primary sclerosing cholangitis. It's a very important disease to rule out. And then, or just bite the bullet and get a liver biopsy. I know we never, I'm talking about liver biopsies like we do it every day, but you guys won't see enough, liver injury to get to a liver biopsy all the time. But really, it's always something to consider. Every time you see liver injury, liver biopsy should be on your mind. So that's for cholestatic pattern. That's kind of the easy part. The more difficult part is the hepatocellular pattern. When you see somebody with with an high R factor, with like hepatocellular pattern, then what do you do? Okay, so I always ask myself two questions. Okay, the two questions are: how much are the AST and ALT elevated? And then what is the AST to ALT ratio? Okay, this AST to ALT ratio is very important. Has a name. I recently discovered that. It's called the de Ritis ratio, but it doesn't matter. It's been discovered like since the 1980s or something. But the idea is that, when you have a shift in this ratio, it can mean different things for different diseases. Which conditions do you think will have a high AST to ALT ratio?
Alcoholic hepatitis.
Alcohol, okay, alcoholic hepatitis. The other one is it's weird. It's cirrhosis will have a high AST to ALT ratio, okay? And the reason, I'm gonna explain to you quickly why alcoholic hepatitis have high AST to ALT ratio, okay? For cirrhosis, it's pretty simple. Remember when we said the AST hangs out in the cytoplasm, but also hangs out in the mitochondria? While ALT does not. ALT is only a cytoplasmic protein. And when you do have cirrhosis, when you have liver injury, you will have depletion of your mitochondria into hepatocytes, and you will have leakage of all the intramitochondrial AST into the outside. And as such, you will have an imbalance between AST and ALT. And always these cirrhotics, you will have a slightly higher AST than ALT. And so you'll have a high AST to ALT ratio in cirrhotics because of mitochondrial damage. In alcoholic hepatitis, that's not the case, okay? Alcoholic hepatitis is a complicated story, but there is this factor, this cofactor. I mentioned it earlier in the early slides, didn't really stress on it, but it's called PLP, or pyridoxal phosphate. This is vitamin B6, active form of vitamin B6. And people with alcohol, they tend to have a deficiency in vitamin B6. Not only that, they also react to B6 in a less, you know, kind of the reaction to B6 are less than people who are non-alcoholic, okay? The reason I bring this up is because PLP is a cofactor in transamination. So in ALT and AST, PLP is a cofactor for both of these reactions, okay? But more so for ALT than AST. So what happens if you have a PLP deficiency, you will have less activity of ALT than AST. And you might ask, so what, right? We measure the concentration. We don't measure the activity, but really we measure the activity in the lab. When you like actually send a blood sample and you say, hey, measure my ALT levels, you don't measure the concentration. They measure activity of ALT, then they plot it, and then they get an assumed concentration. So really, if the activity is low of ALT because of PLP deficiency or vitamin B6 deficiency, then you will have AST higher than ALT. And this also goes for alcohol, somebody who's alcoholic who gets another problem with the liver, like somebody who's alcoholic who gets another type of liver injury, like they get ischemic hepatitis or get something else. They will always have an AST to LT ratio that is almost always 2:1 because they're alcoholics, not because they have alcoholic hepatitis, even if they have another problem causing the hepatitis. So it's kind of important to know, okay? So there's a lot of causes of hepatocellular injury, but in general, if you want to plot them based on these two questions, you will have, the transaminase elevation on the x-axis, right? It's either in the tens, hundreds, thousands, 10,000s, and you have the AST to ALT ratio here, right? Where the higher AST to ALT ratio, this is the AST territory right here, right? And this is the ALT territory down here. So this is normally you hang around here in the tens, and up to 20s, 30s, and AST ALT ratio doesn't really matter. But then, let's say you have elevation in the hundreds right here and high AST to ALT. What is this? What is your differential here in this box? So you guys mentioned it earlier, right? It's alcoholic hepatitis, right? Alcohol-related liver injury, always 2:1 ratio, and it's always less than 300. AST is not more than 300. Hangs around in the, in the hundreds, okay? And cirrhosis. How about if your AST is super elevated, right? But the ALT is not. So you have like thousands of AST and then hundreds of ALT. Then what do you think?
Rhabdo.
Rhabdo, good. So you think of rhabdo. We could think of other sources of AST. Rhabdo, acute MI, like a huge STEMI. Believe it or not, we had a patient, we diagnosed an acute MI based on AST elevation only. Had no like other suspicion. So you can get like acute MIs, but also what I mentioned earlier, if you have medication or toxin-induced liver injury in an alcoholic liver, in somebody who's alcoholic, you will have this kind of disproportionate AST. Now, down here is the ALT territory. This is the, nitty and gritty true liver diseases. This is all your liver diseases that you really like look for. When it's in the hundreds, it's usually these chronic, slow liver diseases. But when it's in the thousands, it's usually these like acute insults, acute things happening. So right here in the hundreds, you'll have, your autoimmune hepatitis, you have your hemochromatosis, medications, all this stuff. You'll have ALT more than AST. While in the thousands, you'll have the acute stuff, acute viral hepatitis, acetaminophen toxicity, ischemic hepatitis, Budd-Chiari. All these things will be in the thousands, but ALT will be predominant, or at least the ratio will be 1:1 or something, okay? Now, if you have ischemic hepatitis, right? Remember, both these are very important differentials, right? You have ischemic hepatitis, you have viral hepatitis or acetaminophen hepatitis, right? Can you differentiate between both both of them will have ALT predominant. Both of them will be in the thousands. Is there a test that can lead you one way or the other? Like a blood test?
Viral hepatitis panel.
Let's say you want to okay, viral hepatitis panel, right. Before the viral hepatitis panel,
Can
is
you
there
look at
something
other
else?
labs? Can you look at
Another
other
lab,
labs,
yeah.
like kidney function to see if that's high as well, just to see if there's
That will
like
help
high.
you, but there's a lab that actually helps you quite a lot, and that's LDH.
Like LDH.
Yeah, there you go. So LDH. So there is a ratio, another ratio. We love ratios in liver. So ALT to LDH ratio. If this ratio is less than 1.5, it's likely ischemic. If it's more than 1.5, it's likely acetaminophen or viral. And sensitivity is pretty good. It's 94%, 84% specificity. So it's a pretty good thing to always look at the LDH as well when you see such high numbers. Okay. So this is like a quick exercise I want to go with you guys through. The final question I want to ask is, which of these guys is the sickest patient? Okay, but before, let's go over it one by one. Okay, so patient number 1. Okay, what does he have? So AST is 300, ALT is 130, TBL is 4, ALK-Phos is 100, GGT is 90. Albumin 3.5, INR 1.3, platelets 200, and LDH is 50. What's going on here?
Hepatitis.
So is it hepatocellular or is it cholestatic? What's the ALK-Phos?
Looks like hepatocellular.
It's hepatocellular, right? So the two questions: what's the AST to ALT ratio?
More than 2 to 1.
More than 2 to 1, and it's in the hundreds. So what's your diagnosis?
Alcoholic hepatitis.
Alcoholic hepatitis. Perfect. So this guy has alcoholic hepatitis. Okay, guy number 2. AST is 10,000, ALT is 100, and the rest of the labs are kind of unremarkable, except like INR is a little high, and LDH is 5,000. So what's going on here? Again,
Ischemic.
Again, look at the AST and ALT.
Rhabdomyolysis.
Disproportionate, right? Exactly. So this guy is rhabdo. This is the typical rhabdo. So this you will send aldolase, you'll send CPK, and they'll both be high. Okay.
Why not MI?
I mean, you're gonna send CPK anyway, so you'll see if CK is high. It can still be MI, but when you see in the thousands, usually MI, you'll see it in maybe hundreds. It will be elevated, but maybe in the hundreds. Not that, because I mean, it depends on how much muscle you lost. If it's like an LV infarct, then yeah. Okay, patient number 3. You've got AST 80. Mild elevation, ALT 70, TBL 4, ALK-Phos 40, GGT 30, albumin 2.1, INR 3, platelets 140, and LDH is 100.
Cirrhosis.
Cirrhosis, okay, this could be, right. So this guy could be cirrhotic, okay? We'll come back to this maybe a little bit later. Okay, let's do patient 4. So 10,000, 12,000, TBL1, ALK-Phos 200. So this is hepatocellular or cholestatic?
Drugs.
Hepatocellular.
Hepatocellular. Okay.
Maybe.
And so what's going on here? Is
Drugs.
drugs? What else could it be?
Ischemia.
Ischemic hepatitis. Okay.
Yeah.
Viral? Can it be viral?
Yeah.
But I feel it's too high for viral.
Acetaminophen. So drugs. Can you differentiate? We said earlier. Can you differentiate viral from ischemic?
So 12,000 divided by 5,000.
Yeah, LDH is very high. It's 5,000. So
But
I would say
12,000 is also too high. So 12,000 over 5,000 is higher than 1.5. Is it?
Yeah, it's, the ratio is like 2.5.
Yeah. So it's more likely to be viral or Tylenol than ischemic. This one. How about patient 5? So it's similar kind of, AST, ALT, thousands, but then you also have ALK-Phos and GGT like crazy. And then you've got an LDH of 2,000. What's going on here, patient 5?
Obstructive.
What's that?
Biliary obstruction.
No. So this is still a mixed pattern. And in my opinion, this is more likely to be hepatocellular primarily, and it's likely to be ischemic hepatitis. And the reason, the reason I say this is because the LDH is super high compared to ALT. So this is like a typical ischemic hepatitis.
Yeah.
Okay. So who's the sickest patient?
Patient 3.
Patient 3. Why?
Because he's in, I think, full-blown liver failure.
No liver anymore.
Perfect.
Oh, yeah.
Patient 3, he's in acute liver failure. Why? Because his INR is 3. Okay, everything looks fine. Well, not really that fine, but look at that albumin. His albumin is 2.1, has an INR of 3. That should be just, flashing in your brain that something is going on. Okay, regardless. So the point also of this exercise is that really the degree of elevation does not correlate with the extent of liver injury. You can have extensive liver damage and in fact have low ALT and AST, okay, and be in acute liver failure, okay? So what is our approach in general? When somebody has asymptomatic elevation of LFTs, what do? We throw the liver bomb, right? You ever hear about this? So this is what we call the liver bomb. So first you take history, you look at alcohol, you look at over-the-counter drugs, all that stuff. You exclude CPK, aldolase, you exclude muscle disease, you exclude toxins and stuff, see what happens. But then you send all these tests, okay? You're gonna send the hepatitis A, B, C serologies. You're gonna send iron TIBC and maybe ferritin. You're gonna send ANA, SMA for autoimmune hepatitis, SPEP for both autoimmune hepatitis, amyloidosis. You're gonna send ceruloplasmin for Wilson's if the age is less than 40, and you're gonna do a right upper quadrant sono with Dopplers to check for the portal vein hepatic vein patency, okay? So this is your typical workup for any elevation of liver enzymes that is hepatocellular, okay? Even non-hepatocellular, but usually when it's hepatocellular, this is what we do, okay? If everything is unrevealing, then we can send more stuff like alpha-1 antitrypsin, TTG antibody, because celiac disease is associated with liver disease, and thyroid functions. And if everything's unrevealing and you still have ALT-AST elevation, then you end up with a liver biopsy. So this is typically our kind of, and depending on what you find, then you're gonna end up doing whatever, if hemochromatosis, you check the gene and all that stuff, okay? So, but really you should, as primary physicians, you should be able to send this workup. So you refer them to GI or liver, but then you also have this already sent so that, they can deal with it. There's one more law called the Hy's law. This is for drug-induced liver injury. Just know that, as I mentioned earlier, when you have hepatocellular liver injury from a drug and you have jaundice and you have T-bili elevation, it's very poor prognostic sign. Can be up to 50% mortality if you don't stop the drug. So always look at the T-bili when you have hepatocyte injury, okay? How about treatment? So how do you treat in general, right? It depends on cause, right? How do you treat it? Depends on cause. So when you have more like acute insult, right? I'm gonna focus here, an acute insult of liver injury. Then, you identify the cause, then you do your specific therapy, right? If somebody has alcohol, hepatitis, then you abstinence and maybe use steroids, depending on, the Madry's factor and all that. Hepatitis B, you treat them. You give them nucleoside analogs and then you send them home. And, autoimmune hepatitis, you start on steroids, you do as a thioprine, and then drug-induced liver injury, you stop the drug. Wilson's disease, you do plasmapheresis or D-penicillamine. And then for sepsis, sepsis can be a cause. Then you just treat the underlying sepsis, okay? Which, finally, just a few words about acute liver failure, which is something you should be able to identify. You correctly identified earlier. Acute liver failure definition, okay, is what? Anybody can take a guess at it?
Yeah, you should have encephalopathy with basically disturbed liver function. So PT, INR, and albumin.
Okay, so low albumin.
But encephalopathy is a major...
Encephalopathy. Okay, good. So acute liver injury, coagulopathy, INR more than 1.5, encephalopathy. Okay, these are the three kind of criteria. Okay, do you have to have all of them to say acute liver failure?
No,
I know you have to have
2 out of 3.
You have to have encephalopathy. Otherwise, it's not.
So the answer is yes. You have to have all of them. You have to have all of them. Acute liver failure is a pretty intense diagnosis. And what is the treatment?
Transplant?
Transplant.
Mm-hmm.
That's the only treatment. When somebody's in acute liver failure, that's it. They need a transplant or they die. The mortality is up to 100% for people with acute liver failure. So it's not an easy diagnosis to throw, but if you do suspect it, you have to do everything, okay? And that's why there's multiple classification systems. There's multiple people trying to put multiple criteria. You know, you go to Japan, there's a different system than like UK, than like here. It's messy. You have, you know, there is like the hyperacute versus acute, subacute. There's the like fulminant, subfulminant. There is like, you know, late onset, whatever. Like this, you don't need to know. It's just a lot of like technicalities. But what you need to know is these people with acute liver failure, they have, you know, they don't present just with like, hey, I have acute liver injury, coagulopathy, encephalopathy. They present with other things. They're usually in the hospital for other things that kind of, you know, make everything muddy and you're not sure what's going on. So these people with the acute liver failure, they will have brain edema. They will have, you know, encephalopathy. They will be in a high output state, just like sepsis, okay? They will be in a systemic inflammatory response. Again, it's almost like a full-blown sepsis. So this is like, it's like COVID, right? It does everything. So it's the same, right? It does everything. It causes, you know, kidney dysfunction. People with Tylenol toxicity can have pancreatitis as well. That's a good one to know. So really, it's a systemic disease when you have acute liver failure, and the body is trying to react to all that, and it's almost tough to differentiate from sepsis and shock with somebody with acute liver failure. The causes in general here in the US is Tylenol, number one. Okay, so Tylenol, and then, you know, it's kind of weird, but unknown, 18% is unknown, okay? Meanwhile, like you go Southeast Asia, it's hepatitis E virus, about 75%, or like, you know, 50 to 75% is still cause acute liver failure there, okay? So there's multiple causes, but here really you should focus on Tylenol, should always exclude it, okay? So again, we mentioned kind of how to treat these people, but really you have to, you know, deal with them until you get them to liver transplant, right? So you have to get them metabolic nutritional support. You have to prognostically evaluate them if they're fit for transplant, and then you transplant them, and then there's some sort of other therapies. Somebody with acute liver failure are prone to hypoglycemia. Remember, all metabolism happens in the liver. All this is stopped. Glycogenolysis, gluconeogenesis, all this is stopped. So you really want to give them D5 fluids. All these people, and you know, they're an NSLR with D5 always. You don't want to give them any hypotonic fluid. Well, I mentioned it. So because the hyponatremia, right? So they're hyponatremic, prone to brain edema. You don't want to give them hypotonic fluids. You also want to limit their protein. You give them 1 to 1.5 grams per kilogram of protein intake because of encephalopathy. And you trend their ammonia. We always, you know, we hate trending stuff, but here we trend their ammonia. And the reason why is to kind of guide your protein supplementation. You know, the ammonia going down, then it's okay to give them protein. Ammonia is going up, then you limit their protein more. And but does not really provide any prognostic value, even with high ammonia. It's just a trend that you're looking for. You're not looking at absolute numbers, okay? And then you prognostically evaluate them. You look at them and you say, okay, this is the cause, this is what they have, eligible, non-eligible for transplant, right? And then comes in these King's College criteria, other criteria. You don't need to memorize them, just know that they exist. And the King's criteria specifically is the one that kind of is thrown around here and it's common. And it classifies people into Tylenol versus non-Tylenol. And these they have different criteria. It's pretty, you know, strict criteria, you know. So these people with Tylenol toxicity, to get status A, to get a liver, they need to have a pH of less than 7.25. They need to have all of the following: an INR of 6.5, a creatinine of 3.4, and grade 3 to 4 encephalopathy. So pretty bad liver disease for them to get the liver, okay? And again, different criteria for different causes. You know, you'll have different stuff. And this is all in the acute setting, right? How about in chronic setting? Can you transplant people in chronic setting? Can you like look at, scoring systems in the chronic setting? Is there like a score?
The MELD score?
MELD, right? The model for end-stage liver disease. It's here, developed from you guys, from from Boston. The guy who did, he's at Leahy. So the MELD score, right now we have the MELD plus sodium, they integrated it with it, but the MELD score generally this is the equation, right? It takes into account the bilirubin levels, takes into account the INR level and the creatinine levels, and then add 6.4. So, when you have normal bilirubin, normal INR, normal creatinine, it's just, this zeroes out and you get a normal MELD of around 6.43, which they rounded down, okay? So what's nice about MELD is, looks at 3-month survival rate, and the higher the MELD, the lower the survival rate. So again, normal MELD is 6. And then to be eligible for transplant as a cirrhotic, your MELD should be 15. You list those MELD of 15, you list these people for transplant, for cirrhosis. So always any cirrhotic you're taking care of, always calculate their MELD. So 15, just mention that you need to list them for transplant or transfer them for transplant evaluation. And then the MELD can be used in the acute setting only in one scenario, if you have Tylenol toxicity. If the MELD is more than 33 in somebody with Tylenol toxicity, then you list them for they're eligible for a transplant. Okay, and then, finally, liver transplant, you have the indications for liver transplant. We mentioned some of them, but again, it's acute liver failure. Then you've got the chronic liver diseases and all the other criteria. But more important is the contraindications, right? Who can't get a liver transplant? And AIDS, active AIDS, not HIV. Active alcoholism or substance abuse, that's a big one. There's a bunch of other things like cholangiocarcinoma and extrahepatic malignancies, but there is one that I just want to highlight is uncontrolled sepsis. Remember when we talked about acute liver failure, we said it almost mimics sepsis, and this one is it's more or less subjective, right? Like when you see somebody with uncontrolled sepsis, it's tough to really quantify what is the meaning of uncontrolled sepsis, but it is basis for the rejection of somebody to get a liver transplant. Always keep it in mind. And then, finally, just to mention, hepatitis C is really why we transplant most of the time overall. The reason why people get transplants, not alcohol, not acute liver failure. Rarely get acute liver failure. Alcoholic hepatitis recently started getting a lot of transplants. And then just a quick back glance at the algorithm. Remember when we talked about DILI, we said, drug-induced liver injury, you stop the drug, but also, they mentioned this thing, liver dialysis. Anybody ever heard of this?
Yes.
Nice. So you should hear of it because Dr. Jaber and Evan, one of our old residents, wrote a nice review about this liver dialysis, and it's called albumin dialysis. And really it's made of, there's 2 types of it. There is an artificial liver support system where, you take out, it's like a normal dialysis. You use a vas cath and you take the blood out, and then you essentially use albumin as, as again, the garbage disposal to infuse back normal, albumin. So you dialyze the albumin out, you give them normal albumin. And there's the bioartificial systems that sometimes use kind of, pig livers and stuff. It's like pretty complicated systems, but essentially they're glorified albumin infusers into the body, and they just predispose, they take out the toxins this way. Meanwhile, they can't really maintain metabolism. So they're really used as a bridge until you get a transplant. And, it shows some promise in people with encephalopathy, but really there is no mortality benefit yet. Okay. We're just going to end with a quick board question. I think we're almost out of time. So just a quick question. Okay, 30-year-old guy evaluated for a recent onset of confusion and jaundice over 6-week duration. Medical history unremarkable. Physical exam, he's confused. Temperature is normal. Blood pressure is 102/60. Pulse rate is 115. Breathing 22 a minute. He's jaundiced and he has asterexis. No organomegaly. His hematocrit is 38%, leukocytes is 11,000, platelets 350. His INR is 2.6, ALT is 200, and AST is 150. TBL is 18.6, and creatinine is 3. On abdominal ultrasound, liver is normal, there is intact vasculature, no splenomegaly or dilation of the bile ducts. So what's going on? Anybody want to diagnose this guy? What? So is it hepatocellular injury or cholestatic? So ALT is 200, AST is 150. And ALK phos, not even mentioned.
Hepatocellular.
Hepatocellular. Okay, so he has hepatocellular injury with TBL of 18 and an INR of 2.6 and confusion. What does he have?
Hepatic encephalopathy.
Hepatic encephalopathy. He has
Acute liver-
coagulopathy. He has acute liver injury. Right? He's in acute liver failure. Right? So which of the following is the most appropriate next step in management? Give them FFP, give them dialysis, do an ERCP, or refer for a transplant?
Transplant.
Definitely, right? Refer for transplants. So this guy is in acute liver failure, should be referred to transplant. All right, if you guys have any, I don't know if you have even time for questions, it's already 1. But if you have any questions, you can ask now or ask later.
Just one question. These patients who have acute liver failure and develop hepatic encephalopathy, and they usually, they crash and we take them to the unit, and sometimes they can't protect their airways. We intubate them. So in terms of that sense, is there a certain type of sedation that we need to be on? Because all these sedative medications sometimes are contraindicated in renal failure, liver failure. Is there a certain like propofol or press? Because we can't use benzos in them.
For these people, no sedation. I wouldn't even sedate them if they're so encephalopathic. Don't sedate them, and instead you actually put an NG tube on these people and you do lactulose Q1 hour until they wake up, if they wake up. If they're really in acute liver failure and severe encephalopathy, definitely needs to be intubated, but I wouldn't even sedate them. If you want to sedate, you can use propofol as a short-term sedator. Don't use benzos for sure.
What's your timeline to refer them for liver transplant? I mean, you were at St. E's, you know how you end up with these people and they end up spending like a week or 2 in our ICU before we give up and we send them for liver transplant. Is there an ideal time when we're supposed to send them?
Honestly, as soon as possible. Like what I learned is that, as soon as you suspect that there is some sort of acute liver injury that seems to be getting out of hand, like as soon as the INR starts creeping up, as soon as anything like that starts happening when they develop encephalopathy, I usually right away refer them for transplant. And my institute, for example, we don't have transplants. So we have to talk to people who do have transplants. And I end up calling like Mount Sinai. We usually call those people. So I'm sure, I don't know what St. E is referred to, maybe Leahy or like Tufts. I don't know if Tufts do have it, but usually the GI fellows take care of that. But at the earliest signs of acute liver failure, before it actually develops, like before you get the criteria, I would just right away call, at least get them involved. That okay, we know this. There's this patient who's kind of crashing, and we need to know about this. So it's as soon as possible. All right,
Okay, so
cool. I hope you guys enjoyed.
Yeah. I think we'll conclude the conference. Thank you so much, Mohammed. That was very helpful.
Thank you.
Excellent. Thank you.
Take care, guys.